All right. Welcome. I think it looks like people have had a chance to log on here. We're still ticking up. Let me give it just one more minute as people get online here. All right. Welcome. This webinar is hosted by the Great Plains Quality Innovation Network. We are the Centers for Medicare and Medicaid Services Quality Innovation Network, quality improvement organization for North Dakota and South Dakota. My name is Heather Wilson. I am a clinical social worker and a quality improvement advisor with Great Plains Quality Innovation Network and Quality Health Associates of North Dakota. I want to thank you for joining us today. Before we begin, there are, as always, a few housekeeping items to review. We are recording today's webinar and it will be posted to our website in 1 to 2 business days, and that is at greatplainsqin.org. All lines will be muted throughout the presentation. Please add any questions or comment to the chat section. We'll allow time at the end of the presentation to respond. Again, thank you for joining this webinar, Decreasing Stigma and Increasing Access, Treating Opioid Use Disorder in Rural Communities. We have the privilege of hearing from 2 members of the Opioid Response Network today. The Opioid Response Network, ORN, provides education, training, and consultation. Every state and territory have designated technology transfer specialists, or TTS, to facilitate this work. These TTS are your local point of contact to work with you and the ORN consultants in your community to meet your needs. This 1-hour webinar will discuss the importance of screening for substance use disorders, an overview of medications for opioid use disorder, MOUD, and how it looks in a rural hospital, clinic, and treatment facilities. Presenters will also discuss how stigma impacts the treatment for individuals with substance use disorders. Our 2 speakers today are Dr. Melissa Henke and Grant Lanois, and I will turn it over to them.
Okay, thank you, Heather. So I am going to start. Again, I'm Dr. Henke. I'm the medical director of the Heartview Foundation in Bismarck, Candu, and Dickinson, North Dakota. And I'm also the medical director for the North Dakota Professional Health Program. And I work with Abby and Grant. Grant is actually my go-to person in Candu. So it's really always fun to present beside Grant. So I'm going to share my screen. I'm not super good at Teams, so hopefully this works. All right. So here we go.
Perfect.
All right. So again, these are objectives of the talk. You guys all should have gotten this in your email. Just to give you an overview of what we're going to talk about. I'm going to hit on 2 of them, and Grant is going to talk about another 2. And then at the end, we'll sort of tag team any questions. Again, these are my topics. We're going to talk about opioid use disorder and then medications. And then I'm going to briefly talk about stigma, because I think if we don't start having a conversation about stigma, it doesn't matter what else we talk about. We're not going to change the way the world views substance use disorders. So DSM-5 really redefined substance use disorders as a spectrum of pathology and impairment. And the criteria are the same, regardless of the substance. If we're talking about cannabis or we're talking about alcohol, it really doesn't matter. There's 11 criteria. There's biological criteria, psychological, and social criteria. Again, it's a spectrum. So if you hit 2 of those criteria, you're going to end up with a mild diagnosis. But at the end of the day, I'm not a big believer in memorizing criteria. At the end of the day, an SUD is a problematic pattern of substance use leading to clinically significant impairment or distress. So if you're seeing someone in your office, in your facility, that's saying, listen, this substance that I'm using or ingesting or whatever is really impacting my life in a negative way, they probably have an SUD. And at that point, you can get out the DSM-5 and look at it. But if they're saying it's a problem, or even if they're not saying it's a problem, but you can see that they're having problems, then it is worth discussing and going down the road and looking at those specific 11 criteria. Where are we at here? So when we talk about medications for opioid use disorder, methadone is a full agonist. Buprenorphine is a partial agonist at the mu receptor. It's an antagonist at the kappa receptor. So buprenorphine really has a very complicated mechanism of action. And then naltrexone is a full antagonist. And I'll kind of describe that in a little better detail. But I really just want you to understand that these medications are all a little bit different. Their functionality and their goals are the same. So when we talk about MOUD, when we were first introducing methadone to North Dakota, there was a lot of pushback and people saying, you know what, we don't want these medications. You're going to have more homelessness. You're going to have more crime. But when you look across the globe, every time people have studied medications for opioid use disorder, and methadone's been around since the 60s, every time they study it, it has been shown to improve survival. It increases retention and treatment. And I don't care what illness, disease we're talking about, the longer you keep people engaged in treatment, the better your outcomes. I don't care if we're talking about Parkinson's disease or cancer or diabetes. If you treat someone for 30 days and then discharge them from your clinic, they're not going to do well. If you treat them for 30 days and then you get creative and you start changing up their treatment, but you keep them engaged, they're going to do better. MOUD will decrease illicit opioid use, decrease hepatitis and HIV, decrease criminal activities, increase employment, and improve birth outcomes. For moms that are using, if you can get them on MOUD, they will do better and so will their babies. So to start with methadone, it has been around the longest. It's a long-acting synthetic opioid, so can be dosed once a day. And again, synthetic just means it's dosed in a lab or it's created in a lab. It does not come from the poppy plant. Higher doses are more effective. And prior to the fentanyl epidemic, we used to say average daily doses were 80 to 120. Now what we're seeing is probably 130 to 200 milligrams a day of methadone because of the potency of fentanyl. And good outcomes are contingent on length of treatment. This is not meant to be a 30-day treatment, a 90-day treatment. It is really meant to keep people engaged for a long period of time. Only available through an opioid treatment program. And again, Wyoming is the only state that doesn't have an OTP. North Dakota was the 49th state. The rules are pretty specific when you're talking about methadone. This is not an easy program to be compliant with. Clients are required by federal law to see a licensed addiction professional every month. So as a physician, I can't just go and decide that I'm going to set up an OTP. I have to have licensed addiction professionals that are going to maintain contact with my clients on a regular basis. A minimum of 8 urine drug screens are required every year, and people will dose daily out of an OTP. The take-home doses are earned based on compliance with the OTP, as well as 8 federal rules. And recently, the time that's assigned to these rules was changed a little bit because it was felt that the criteria was very stigmatizing. Historically, you had to dose for 2 years before you could have a month's worth of medications. And again, there was a big pushback from OTP saying, wait a second, this isn't fair. Somebody can go to their psychiatrist and get a Xanax prescription or a Provigil prescription, and they don't have to come in every single day. Why on earth would someone have to be compliant for 2 years to get a month's supply of medication? So they are now giving a little bit of flexibility to the OTPs. But at the end of the day, these are still the criteria that have to be met before someone can have take-home doses. So absence of recent drug use, regular attendance, no behavior problems, no recent criminal activity, stable home environment. You have to be able to safely store your meds. So when people come to pick up their methadone from Heartview, they can't just stuff their pockets with it. They have to have a lockbox so that we know that when they leave our facility, they're able to safely store those medicines. We also need to know that they're not living at a flop house or living in the park. And then there has to be rehabilitative benefits to not coming in, whether that's they need to go to work every day or they need to get their kids to school, whatever it is, there has to be a reason. This is just some data that came out of the Heartview Foundation. And again, we've been doing this for, I think, about 6 or 7 years now. So this is just some of our data. And again, it's a little bit older. It stems from February of 2022. But if you look at it baseline, we had about a third of our patients employed. At 1 year follow-up, we had about 70%. Average or mean days worked, it was less than 6 to up to 12. their monthly income, and you can see that my patients are still relatively underemployed. A lot of that stems from the legal history. Mental health improved. 47% initially said they had fair or poor mental health. At 1 year follow-up is down to 24%. How many of them had been arrested? 90%. And then at 1 year follow-up, how many had been arrested in the last month? It was 4%. How many injected drugs? The vast majority of my patients have been injection drug users. And again, at 1 year follow-up, only 9% had injected in the last month. How many had overdosed? 61%. And I think that now, as we are further into the fentanyl epidemic, if we looked at that number, it would be far higher than 61%. I couldn't tell you the last time I saw a new patient who had an overdose. Okay. And then again, if you look at 1 year follow-up, less than 0.8% had overdosed in the last month. And how many were treated in the emergency department at baseline? Almost half. And again, at 1 year follow-up, 3%. So if you're looking at, is methadone really beneficial? If you're looking at a cost savings, if you're looking at harm reduction, this is really a very dramatic and effective method of treatment. So switching gears from methadone to buprenorphine, Subutex is buprenorphine alone. And historically, we used to say that this was safer in pregnancy, that the naloxone component of Suboxone may have had a downside for baby. The data now really shows that Suboxone, which is a combination of buprenorphine and naloxone, is perfectly safe in pregnancy. And so we have been going that route. So when you look at these medications, and again, I'm just going to do a little generic graphic here. So like if this is your opioid receptor, and I'm taking fentanyl or heroin or something along those lines, it binds to that receptor. I get the downstream release of dopamine, and that's what feels good. It's what lights up the pleasure centers in my brain. Methadone acts in very much the same way, except it binds very slow and it binds very tight. So it comes in slow enough that I don't get the euphoria, but it also binds very tight so that if I'm taking methadone every day and then I use fentanyl, I don't get the high because the methadone holds its place and the fentanyl can't bind. Okay, with buprenorphine, it's a partial agonist again, so it kind of half sits on that receptor. So it binds in such a funny way that it doesn't cause the euphoria, but it also binds in such a funny way that if I use fentanyl or heroin or oxy, it can't bind and I can't get the euphoria, okay? And it also binds really tightly. We're going to talk about naltrexone, which is really, in my mind, I think of it as a long-acting naloxone. So it puts a ceiling effect on that receptor. So it kind of blocks it. And again, it binds very tight so that if I use anything on top of it, it's not going to be able to bind. But because something is sitting on those receptors, I don't have the cravings that I would normally have. Okay. So when we're talking about buprenorphine, the most common product we're talking about is Suboxone, which is a combination of buprenorphine and naloxone. The naloxone is Narcan. That's really only there to prevent it from being injected. Okay. Comes in tablets and strips. Both are generic at this time, but they can be expensive. Zubsolv is the same medications, but it apparently tastes better. And then we have a long-acting injectable. So Sublocade is a once a month injectable, and Brixadi is a either a weekly or a monthly long-acting injectable. And so for people that are concerned about medications being diverted or someone not being able to keep it safe, these are really very novel agents that can kind of be game changers in that regard. Buprenorphine has been around a long time. It was approved in 2002. Again, it's that partial agonist. Low risk of abuse, addiction, and side effects. Again, it can go under your tongue, subcutaneously injected, or there was historically an intradermal product, though I think that has since been pulled from the market. There's no evidence of organ damage. Heavily regulated by the FDA historically. The rules recently changed. So when I started prescribing, I had to take an 8-hour course because I'm an MD. When Grant started prescribing, he had to take a 24-hour course. The last administration changed the rules so that anyone with a DEA can prescribe these medications and there are no limits. But unfortunately, those initial rules of additional training really left a bad feeling in a lot of people's mouths that this must be a dangerous medication. There must be something to it. Why did we have to have all these extra rules? And so now we're working really hard to get people to understand that this is a very safe medication and needs to be utilized more. And then lastly, naltrexone. Again, it's the antagonist. Daily doses of 50 to 100 milligrams. If you if you start using really high doses in patients with morbid obesity, there is some risk for hepatotoxicity. And again, naltrexone is actually approved for both opioids and alcohol. So if you still have opioids in your system, again, think of this as a long-acting Narcan, you will put them into withdrawal. So when I think about naltrexone, somebody really has to be coming to me either from incarceration or a long-term hospitalization because they really have to have all of the opioids out of their system, or I'm going to precipitate withdrawal with that. Compliance can be a problem with daily dosing of these meds, which is why the IM version is much more commonly used every 28 days. 380 milligrams, again, ordered through a specialty pharmacy. And I think Grant's going to touch more on how do you do this in rural America. And again, the biggest thing with any of these antagonists is that somebody has to be through their withdrawal before you can consider utilizing these medications. So there's lots of stigma out there about MOUD, but just from a scientific standpoint, when we're talking about dopamine levels in the brain, an average brain on any given day is sitting at about 50 nanograms per deciliter of dopamine. Buprenorphine and methadone return that dopamine level to normal. So if dopamine is the feel-good chemical in our brain, when we use heroin, we can push that dopamine level up to almost 1,000. Methamphetamine is even higher. Buprenorphine and methadone are really raising dopamine to normal levels. People who have low dopamine levels, they don't stay in treatment. They get sick. They don't feel good. Less than 10% of them will stay in treatment. And mortality rates for people who are pursuing an abstinence-based recovery is 10 times higher than people who receive any sort of MAT or MOUD. And again, not surprising, just like everything else in medicine, if you take a medication and you combine it with psychosocial treatment, people are going to do better than if you do one or the other. So for people that have a reluctance to consider MOUD, I think this data is pretty convincing. So what are the other benefits? Well, having an opioid use disorder increases the risk of premature death tenfold compared to the general population. And it's kind of an oxymoron, but people who survive an overdose are more likely to die of an overdose. So 1 in 20 people who will survive an opioid overdose die within a year. It's a 5% mortality rate. It's not great, right? 20% of them will die within the first month. So when I talk to people who don't have any experience with substance use disorders, they think that if you were to survive an overdose, that would be a deterrent to ongoing use. But unfortunately, it's just the opposite. People who survive an overdose are more likely to push the limits and actually experience another overdose. And MOUD, utilizing it is associated with decreasing overall mortality by at least 50%, right? So during the first 4 weeks of treatment, buprenorphine is associated with a 90% lower mortality rate. Methadone is associated with an 80% lower mortality rate, and both are associated with a 40% lower mortality rates after the first 4 weeks. So again, the most robust change is in those first 4 weeks, but even after that, it's significant. Reduced mortality rates associated with buprenorphine hold up even if the person stops taking the medication. So if you can get them started on buprenorphine and start working with them, their overall mortality rates will decrease over time. The mean duration of treatment is actually longer with methadone compared to buprenorphine, and some of that is because there's a lot of accountability associated with the methadone, and so people tend to stick with it a little bit longer. What about stigma? Well, the stigma towards MOUD, especially in the self-help recovery community, is that it's just trading one drug for another. Keeps people sick. People on MOUD aren't really in recovery. They aren't really sober. I've heard lots of things. People who are taking MOUD aren't allowed in certain sober living homes. They're not allowed to speak at certain 12-step meetings because that community doesn't feel like they're actually in recovery in sobriety. So to talk about stigma, um, I always think we need to start talking about stereotyping. So, what is stereotyping? People will judge each other based on behavior, and we sort of group people into categories based on very simplistic generations. It's not necessarily harmless, and it's not necessarily useful, right? But it becomes corrupted when those stereotypes become very negative. So, when we look at these pictures, right, we can all have certain stereotypes about these these figures, right? They're obviously sports fans. They probably pretty harmless, right? If you were in Minneapolis on a Sunday, the Vikings had a home game and you ran into that guy in the middle walking down the street, you wouldn't necessarily think much of it. But what if you run into one of these people in that same scenario, right? We're walking down the street on a Sunday evening in Minneapolis and you run into one of these. Um, and words have power. We know that if we use things like junkie, tweaker, meth head, dope fiend, people have automatic ideas about them and they're not positive, obviously, right? So, some stereotypical beliefs about addiction is that it's a choice. If they really wanted to stop, they would. Drug addicts or criminals, we should just send them all to jail. That's the only thing that's going to help anyway. Or let them suffer. They deserve it. Treatment doesn't help anyway. Nobody actually gets better. These are things that I hear from families all the time. They're things that I hear from just people in the medical community all the time, right? So, stereotypes contribute to stigma. So the word stigma actually comes from the ancient Greek word meaning a tattoo or a puncture mark. So at that time, we branded our slaves much like we brand cattle, right? So if someone were a slave, they would have a certain mark on them. That way, if they were found in the community, they would be taken back to their rightful owner. Goffman said in 1963 that stigma reduces someone from being a whole and usual person to a tainted and discounted one. And Oxford said it was a mark of disgrace or infamy, right? We've seen this before. Because of stigma, an entire group of people were slaughtered. It was total genocide, and it was actual branding, right? We branded them with numbers, we branded them with yellow stars and purple stars and pink stars, and it wasn't just Jewish people, right? We branded entirely different groups of people, and because of that stigma and how powerful public stigma is, it allowed an entire group of people to almost be eliminated. So, public stigma occurs when the general public endorses negative stereotypes and then discriminates against them, right? And it might be benign, but it might be very significant and allows them to be hauled off in trains and led to their death. It excludes people from public engagement by seeing them as unreliable and untrustworthy, right? Like, I'm not going to rent to someone who has a history of drug charges because I know that they're not going to pay the rent anyway. I'm not going to employ someone who has a history of legal problems because, well, they're probably just going to steal from me, right? This is what public stigma does. Um, Public stigma towards people who use drugs found that people think they're dangerous, they're unpredictable, that you're irresponsible, and it's really their fault that they're in this mess to begin with, right? So again, hopelessness, worthlessness, and blameworthiness. What happens when people who are in that stigmatized group hear about these stereotypes is they sort of internalize them and believe them to be true. Leads to shame, reduced self-esteem, social withdrawal, hopelessness, and demoralization. And unfortunately, at the end of the day, when you feel all of those things, you end up going back to use because everyone thinks you're worthless anyway. Everyone thinks you're going to steal from them anyway. You're not going to show up to work anyway. So you know what? I might as well just go use drugs and not show up to work anyway. Self-stigma is very pronounced in addiction. And why does it matter? Because if you start to feel that way about yourself, you don't actually seek help because you think, nobody's going to help me anyway. I don't deserve it. I probably couldn't figure it out anyway. People might act out more. Historically, we've had reduced public funding for services, and I will say that in North Dakota, we're very blessed. We have a first lady who has taken this on as her platform, and so we have actually seen increased public funding for services. Finally, it's not enough, but it's something. Stigma may contribute to suicidality and shame. And shame is actually just a painful emotion caused by guilt directed towards yourself, right? And it can really be compounded and it can really increase over time. It is very counterproductive. It affects quality of life, and people lose their motivation to even try to heal because they feel like they're not worth it. And again, it reinforces that drug use because at least if I'm high, I don't have to think about how awful I feel about myself. And at least if I'm high, I feel something good. What about stigma in healthcare, right? Because that's why we're all here. There's actually a ton of literature documenting how common stigma is in healthcare. It can range from outright denial of care, substandard care, physical and verbal abuse, subtle forms such as making certain people wait longer or passing their care off to junior colleagues because you don't think of them as being worthy of your care. And it leads to people not seeking services because they don't want to deal with it. And electronic health records have really compounded this. If you go to the emergency room and you're diagnosed with a substance use disorder, it now lives in your chart forever. Everyone that opens your chart sees that. And so it becomes really a barrier to people wanting to go in because they get treated a certain way. What drives that stigma in healthcare? Well, it can be lots of things, negative attitudes, fear, right? People are afraid to take care of someone who has hepatitis C because I don't know what that means. It may just be that I don't understand substance use disorders. I don't know how to help, so I just don't want to deal with it. Um, and again, policies and procedures, practices may contribute to this stigma. Or people might feel like they're morally on a different plane, and I don't agree with people living that way, and I don't think I should have to take care of them. So how do we reduce stigma? Again, I always feel like if we put people in a room, we'd realize that at the end of the day, we're all just human beings doing the best that we can. Some days are good, some days are not so great, right? So if we can have contact with that stigmatized group, put them in a situation where we can see them as a human, we can see them as something other than their diagnosis, we can develop empathy, we can break down those stereotypes. If we can teach someone who's in that stigmatized group to be assertive, speak up, talk about yourself in a positive way, learn some coping mechanisms that might change how people interact with them. But really, at the end of the day, we need to change policies. We need to educate. We need to really make this what it's supposed to be. We went into healthcare to treat people, right? We didn't go into healthcare to treat people that were just like us. It's I want to take care of everyone that comes into my office. The most effective strategy for changing stereotype again is personal contact. Get people in a room together and you realize we're really not all that different, right? When I talk to high school kids, and I talk to a lot of high school kids and middle school kids, I ask them, what do you want to be when you grow up? And it's doctors, lawyers, teachers, police officers, all of those things. I say, how many of you want to use drugs? How many of you want to be an alcoholic? It's none. I've never met a single kid that wants this path. I've never met a single patient that's like, this is really what I wanted for myself, right? They ended up here because they made a series of choices and their brain was hijacked by substances. They don't want this life. It's our responsibility to help them find a different life. Okay. So take home points and then I hand it over to Grant. There are treatment options available for MOUD. We've got 3 FDA approved medications. We've got methadone, we've got buprenorphine, which comes in now a long acting injectable, whether it's weekly or monthly. And we've got naltrexone. Don't overthink this. People with a substance use disorder, at the end of the day, are just people with a chronic illness, just like cancer, just like diabetes, just like Parkinson's or dementia or any of those. Don't overthink it. Treat them as people. Find out what their goals are. Find out what they're willing to do. Find out what you're willing to do, and then work together. MOUD is life-saving. Reducing stigma will absolutely improve access to MOUD. If we can get people to understand that this is an illness and these are just human beings who want a better life, more people will be willing to prescribe and take care of this population. Every single one of us can reduce stigma. If you're standing at the water cooler and you hear people saying negative comments about someone with an SUD or someone's kid who had to go to treatment again, use your voice, stand up, tell them that's not okay. And the Opioid Response Network is awesome. Call Abby, use her information. She can provide free education to your staff. We can come in and provide lots of resources and all of those things. You just have to ask. And so that's going to end my part of this. And I'm going to hand it over to Grant.
Excellent. Thank you.
Hello, can you guys hear me okay? Okay.
We
All right.
can.
Yep, thank you.
I am also not very familiar with Teams, so let me try sharing my screen here. Okay, see my slides?
We do.
All right. And if you still see me, you're going to see me looking out to the side because I have 2 monitors here.
And we do still see you. And now it's just the slide.
Okay, there we go. All right. So they asked me to speak on a couple things here, kind of how do we integrate MOUD into rural clinics, but don't discredit, say you're in Fargo, you're in Bismarck, and you're not a rural clinic. This can apply to any primary care clinic, okay? And kind of the key components for doing a successful MOUD program. So I guess, well, there's our objectives, right? So right away, I'm just going to cover the key components here, because as I go through how we start implementing MOUD, how you start treating patients, we're going to kind of touch on these key components too. So number one is assessing the readiness. And I put this for both the provider and the patient, right? Because as Dr. Hankey alluded to, with all the training and stuff like that, there was a lot of providers that were like, oh, I don't know if I want to do that. I don't know what that is. And I think it's the fear of the unknown. So you have to get your staff, your providers, your prescribers, your clinical pharmacists, whoever it may be, on board. And then developing partnerships. And at the top of the list there, I put colleagues. And I think that's really important. When we started doing this here in Candu, North Dakota, I didn't do it alone. I had my nurse practitioner colleagues that also went through all the training and whatnot. Like Dr. Hankey said, she had to do 8 hours of training. I had to do 24 because, as we all know, PAs and NPs are inherently less intelligent than physicians. Just kidding. But I'm glad they've gone away with that, but I think the damage is done. But if you have a DEA number, you can prescribe this. If you can prescribe Xanax, if you can prescribe hydrocodone, you can do this. This is safer. Other partnerships, treatment facilities, inpatient, intensive outpatient, things like that. Social workers are wonderful. I like to use them a lot. Licensed addiction counselors, that kind of goes hand in hand with behavioral health. And then, as Dr. Hankey mentioned too, educating your staff, reducing that stigma, right? Using the appropriate language. And then monitoring, I think, is also a key component, doing your urine drug screens or serum drug screens, right? We utilize pill counts here as well, which can be challenging. Fortunately, there's some technology out there that makes that easier. So people that are logistically challenged don't have to find a ride, get to a pharmacy that's 30 miles away, do their pill count and all the phone calls and whatnot. The technology is great. And then follow-ups. When do you follow up, and what is the right time, I guess? So let's move on here. So how do you get started? These are kind of the steps. You have to identify or screen those patients. Then you have to have that approach. How are you going to approach this patient? How are you going to bring this up? Hey, I think we may have a problem here. That's not an easy task. And then initiate the MOUD, start the medication. And then as well as you have to have supportive medications for, say, co-occurring conditions, right? You can't ignore their anxiety, their depression, their insomnia, things like that. And then you also have to have support beyond the exam room. So we talked about licensed addiction counselors, treatment centers if they need, et cetera. And then MOUD agreement, which I'll just touch on briefly, laboratory assessment, and then follow up again. So screening tools, as Dr. Hankey said, she's not a fan of memorizing criteria. Neither am I. And just as a disclaimer, everyone, I do not have any special addiction medicine background. So I am not an expert, I wouldn't say. I'm very experienced, I would rather say. I'm a PA who started in rural North Dakota, and it just so happened that the residential treatment center nearby was opening when I was a new provider, and I had lots of openings. So I kind of fell into treatment of substance use disorder, and I really enjoy it. But anyhow, we're going to cover some screening tools here. Dr. Hankey and I talked before this, and these are a couple of the screening tools that you can use if you can't just recognize it right off the top, or if you need something like this to help show the patient, hey, look, let's do this screening. Here's your score. Here's the risk. So that we talk about here, the CRAFT screening tool. Then there's single question, and then the CAGE is also a very common one. For sure, a lot of you know the CAGE one. So if we look at the CRAFT screening here, so part A is during the past 12 months, did you drink alcohol, smoke any marijuana or hashish, use anything else to get high? And then did you answer yes to any of the questions of part A? So if yes, then we continue, right? So then we go on to part B. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using drugs or alcohol? Did you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Have you ever used drugs or alcohol by yourself when you're alone? Do you ever forget things you did while using? Do you or your family ever tell you should cut down on your drinking or drug use? Have you ever gotten in trouble while you're using drugs or alcohol? So then if you look at the scoring of the CRAFT here, we have your score And then we have your probability of substance use disorder, basically. And even if you score 1, they're putting your probability of substance use disorder at about 30%. And it just goes up from there. So this is a relatively simple thing you can kind of keep in your back pocket. Per se, there's like MedCalc apps on your phone, right? You can star it, you can pull it up real quick. I use that for all sorts of screenings on the fly. It's handy. So then one question screening test here. How many times in the past year have you used an illegal drug or used a prescription medication for a non-medical reason? So because of the experience or the feeling it caused, euphoria, or it helped you forget the anxiety and the stress of the day. So, and then just with that one question, if they say, once or twice, then you should take that positive answer and follow it up with something a little more thorough. CAGE questionnaires. So the CAGE is your acronym: cut down, annoyed, guilty, or an eye opener. So yeah, the original CAGE was geared just towards alcohol, but now I believe the modified is called the CAGE aid, which basically instead of alcohol says substance, right? So have you ever felt you should cut down? Have people ever been annoyed or criticized by your use? Have you ever felt guilty about your use? Or have you ever used a substance first thing in the morning to kind of steady your nerves, start the day, the kind of hair of the dog type thing? So answering yes to 2 or more questions suggests you might have a substance use disorder. So how to get started? Like I said, this is just kind of my approach, how I've learned things. And it's just, again, an example that you don't need any special training. You don't need to be an addiction specialist to do this. You can do this anywhere you are. So, and you have to know that this is going to take time, whether you work in the ER or clinic or wherever you may be. Good things take time. Oftentimes when I first meet somebody that may be struggling with opioid use disorder and we want to talk about MOUD, you can guess I'm going to be about 30 minutes behind for my next patient because it takes more than that 10 to 15, 20 minutes. There's a lot of things to talk about. Empathy, you have to think about things from their perspective, right? You have to think about where they're at. Maybe they don't have a home. Maybe they've lost their kids. They don't have any money. And just a feeling of not having their substance of choice is a really crappy physical feeling. Body posture, this is another one. Try to sit down, don't cross your arms, don't cross your legs. Don't be standing in the corner with your arms crossed. It's a really uninviting posture. And then the chronic disease model, if you guys haven't heard this before, it's quite simple. You need to think of substance use disorder as a chronic disease, similar to, say, hypertension or diabetes, right? So diabetics, many of them require medications lifelong to help them with their illness, their disease, right? Can it be fixed with exercise, weight loss, lifestyle changes, diet, things like that? Absolutely. In some cases it can, others it cannot, right? So sometimes you need medication. Same with blood pressure. And you may need it lifelong. It depends. Or you just may need it till some things get changed around. So medication, I usually, once I figure out that, hey, this person looks like they're struggling with an opioid use disorder, I try to carefully broach that. And then tell them, hey, I have a medication I think that might be helpful. And usually I'll ask them, have you ever heard of Suboxone, right? And in many cases, if they do have a history of OUD, they'll have even tried Suboxone, whether they got it off the street or from a friend or something like that. So I always tell people too, because this is a tough spot, right? Because they feel like crap. They're probably willing to do anything to feel better. So I just let them know that even though if I give you this medication, you're going to feel better shortly, it's not a short-term commitment. You don't just want to take this for withdrawal. You want to take it longer term, which could be months, years. Trading one drug for another, kind of like Dr. Hankey said, that's just a crutch. Like that's one of my favorite ones. That's just a crutch. Because if you break your ankle and come into my ER, what are you going to leave on today? You're going to leave on crutches, right? Because the crutch is there to help you get better. Yes, you may use this crutch longer, but that's fine. And trading one thing for another, well, that's great. I don't care about that because our Suboxone isn't going to be laced with fentanyl. Interesting kind of off topic here, but I just read the other day that fentanyl, a lot of the fentanyl pills out there are 500 to 2,000 micrograms, up to 5,000 micrograms. That's 5 milligrams of fentanyl per tablet. That is insane. If somebody breaks their arm or their hip and comes into my ER, it might give them 50 to 100 micrograms. So anyways, back to words here. Choose your words carefully. Substance use disorder rather than addiction, right? Don't say dirty in regards to a urine drug screen. Just say, as expected or not as expected. And I find it interesting because I see a lot of people in recovery that still refer to themselves as addicts or junkies, but nonetheless, I still don't use that language, I guess, with them. And again, this takes time. Be patient. It can definitely be worth it. So where can you do this at? Anywhere, right? So I work in rural healthcare. So I work in the clinic, I work in the hospital, I work in the ER, also the nursing home. Fortunately, I haven't had to do this in the nursing home yet. But yeah, you can start this in the clinic. You can start it in the ER. Hospital, yes, that's an option. However, as all of you may know, it is very difficult to get somebody admitted to the hospital without meeting XYZ criteria for insurance purposes. So just acute opioid withdrawal, I don't believe will meet your criteria for hospital admission. So yeah, can you start this, initiate it in the clinic? Yeah, you certainly can if you have it on stock in the clinic, which I'm guessing a lot of places don't. We do, so I will do that occasionally. However, I would say 95% of the time I'm doing home induction. So we talk about it in clinic. I give them kind of a regimen of what to do, when to do it, and I send them to the pharmacy. They pick up their medication, they go home, and they start it. The only time we'll usually do it in clinic or ER anymore is if they're absolute terrible distress. They can't sit still, they can't listen, they can't keep their eyes open, they're nauseous, and we can't even have a conversation beyond that they want Suboxone and they're willing to commit to it. Then I'll do it. I'll come back in 15 minutes, and it's really an amazing transition. So dosing and the initiation here, they may need to plan for a day at home. It all depends. Which for most of them probably is not a big deal because quite honestly, a lot of them don't have anything else to do. They're not holding jobs, right? Usually I tell people to wait until they feel very ill from the withdrawals, right? Until they just can't take it anymore, to the point where is if they had some fentanyl or whatever their drug of choice is, heroin, they would be using it. Then I usually tell patients to start with a half of a Suboxone tablet. Most commonly, the Suboxone comes in 8-2 milligrams. 8 milligrams is the buprenorphine, 2 is the naloxone. You place it under your tongue. I'll tell people to wait an hour. And if you're still feeling kind of crappy, you can repeat that second half of tablet. Now, there are a lot of guidelines out there that are definitely more aggressive with their dosing and their initiation. And I guess that is kind of goes with the change in the strength and the increase of the fentanyl. But everybody's different. But at the same time, there is no algorithm that says, hey, this is John Doe. He does 15 tabs of fentanyl a day. This is where you need to start him. I've had people who do crazy amounts of opioids and do pretty well on lower doses of Suboxone and vice versa. So yeah, and like I said, it's an amazing transition. You give them a half tab of Suboxone if you get the chance in the clinic, come back in 15 minutes later, and it's like a totally different person. So beyond that, like I said, opioid use disorder is a mental health disorder, and it's oftentimes accompanied by others. I guess I can't even recall a patient who hasn't struggled with one of these other things: anxiety, depression, right? I usually tell people when I'm doing their MOUD, I don't necessarily want to be your PCP because you may have other conditions that need to be managed as well, such as diabetes, hypertension. And I've had the experience of doing that before, and say they relapse and they don't come back, and I don't know who's taking care of their diabetes. And so initially, I don't like to be their PCP. Once they have some long term with me, I will take that over. But just some different medications here. Your SSRIs, obviously, buspirone, miscellaneous anti-anxiety agent, quite safe, can be quite effective in some patients, others maybe not so much. Hydroxyzine, it's a first generation antihistamine similar to Benadryl, so it can have some sedation with that. There are different formulations, Vistaril versus Atarax, which they think one is, I think the Vistaril is supposed to be a little less sedating. Clonidine, see it used a lot for anxiety. It is not my favorite, though, due to the hypotension, because it is a blood pressure medication as well. Sleep, melatonin. A lot of people will tell me, oh, I've tried melatonin, it doesn't work before. Okay, well, what dose did you try it at? Was it too high? Was it too low? Was it while you were sober? Maybe try it again. Keep an open mind, right? And then back to the hydroxyzine, Benadryl combination. Trazodone is also a nice one. Sometimes we'll use Seroquel if we need to. Also helps with anxiety. Nausea, that's usually short-lived with starting the Suboxone, but it can be present. For some reason, I don't know if Dr. Hinkie sees this or not, I see it more with my female patients than my male patients. So anyways, you can co-prescribe some Zofran. It's not going to hurt anything. Diarrhea, usually acute withdrawal sign. If you need Imodium, you can certainly use it, but typically that resolves pretty quickly once you get some buprenorphine in their system. Achiness, headaches, right? Get the Suboxone in there, that's probably going to go away too. Otherwise, you got Tylenol, ibuprofen. Gabapentin can be helpful. Can be used for all sorts of things, as I'm sure several of you know. Used mostly, all those things are used off-label, right? Can be used for anxiety, alcohol use disorder, alcohol cravings, pain, itching, restless legs. However, there is that potential for it to be misused too. So it's definitely not something I'm offering somebody on the first visit, you know, and usually if I'm going to be using that, I'm trying to hit multiple conditions at one time with this medication, and we're watching it closely. Narcan, right? Give people a script for Narcan. And there's a lot of public health, right, that'll dispense it for free. So it's easy. You can't hurt anybody by giving them Narcan. So support beyond the exam room, as I mentioned earlier, licensed addiction counselors, social workers, licensed addiction counselors, I feel like are so important with recovery. They're just helpful. They're gonna, you know, talk over those things that I, as a primary care provider, I don't have that knowledge. I don't have that expertise, and I don't have the time either that the licensed addiction counselors, not saying they have time, right? But they have a little more time, and that's more their lane. They can help a lot better with that. Behavioral health, that kind of goes back to some of our medications as well as say counseling, right? Treatment centers, AANA, don't write that off. That can be really helpful for some people as well. Church, family. So agreement. Usually I'll have people sign an MOUD agreement. Basically says, hey, you're getting Suboxone from me. You're not going to get it anywhere else. You're not going to get any other controlled substances from anybody else. You're going to let other providers know that you're taking this. You're going to consent to drug screens. You're going to consent for pill counts. Remind them, you know, there is a risk of taking buprenorphine containing products with benzodiazepines, alcohol, etc., just like any other opioid. Pregnancy, again, very safe during pregnancy. I would rather have a patient go through pregnancy on Suboxone and maybe their infant has neonatal abstinence syndrome, withdrawal in other words, versus a mother overdosing and dying while she's pregnant. Lab assessment. I always like to offer lab assessment to my patients because a lot of times when they're coming in to see you, they haven't seen anybody, maybe ever or in years, right? So just your basic stuff, CBC, CMP, HIV, Hep C, syphilis, gonorrhea, chlamydia. You can do a pregnancy test, you can do a drug screen right then. I don't usually worry about a drug screen on the first visit, especially if they're coming to me in the clinic asking for help because they're already admitting that, hey, I got a problem. This is what I'm doing. I don't need to prove it on paper too. Now, if they're in the ER and you can't find anything wrong with them and you've done everything else, maybe you could do a urine drug screen. Maybe that adds some fuel to your fire. So follow up. Optimally, I'd like to see them back the next day, but logistical financial barriers, we're rural North Dakota, that doesn't usually happen. Mostly my patients will follow up within 4 to 7 days. And then after that, I kind of titrate their medication. Anytime I'm doing a change on their medication, especially in the beginning, if I'm going up, I like to keep them close at least a week. Make the appointment right. If you need to, walk to the front desk and be like, hey, let's schedule this right now. And then that next bullet there, transportation, make sure they have transportation lined up. You know, is there public transportation? Is there insurance through there or transportation available through Medicaid? Is there tribal transportation they can use? And titration. So usually I'll start people on half tab twice a day, have them come back whenever they can, you know, within that first week preferably. And depending on their symptoms, what they're experiencing, what time of day, I'll usually increase by about a half a tab, 4 milligrams, and you can add it to a dose. You can put a third dose in there. So I'm going to step back here. Suboxone was initially made to be a 1 time a day dosing. That being said, I bet 95, 98% of my patients take it 2 to 4 times a day, partly because they say they feel better when they do it like that. And I think part of it is a kind of a placebo effect that addicts are used to doing something multiple times a day, and that's fine. It doesn't matter. So follow up thereafter. There are no real set guidelines, right? I usually see people every week until they're stable for a couple weeks, and then we'll work out to like 2 weeks, 3 weeks, and then usually I do it every 28 days, 4 weeks, right? I like to see my patients maintain on it for about 2 years before tapering off. Tapering can be long and it can be challenging with the tablets. But there is Sublocade. We use a lot of that. That's the injectable long acting. It works really nice for getting people off, even if they're on tablets. You give them 1 injection of Sublocade, and it's just such a long half-life that it tapers them off nicely. So Dr. Hankey mentioned, I believe she said there's a 10-fold increase of OUD with death rate. My sources here from 2015 and 17, just say 6, but regardless here, if you look at the general population and death rates, right? For, we'll just say they're 1, so that's our control. But without treatment with OUD, their death rate is up to 6, or 6 to up to 10, as Dr. Hankey mentioned. But with MOUD, we can reduce that to less than 2. That's amazing. Even if you only go off of the 6 and not the 10, going down by 6, that's a 300% reduction in deaths. So you can implement MOUD in almost any practice, any location. It is not difficult, guys. This isn't something you should be scared or afraid to do. There are people like Dr. Hankey and myself and Abby who you can reach out to. There are all sorts of great resources online you can use. We'd be happy to help you guys get this started. Certainly the number of Suboxone providers are getting better. There are more of them. Several years ago, it was very difficult to arrange for follow-up at different locations because you just couldn't find them. But the more places we can get involved, the better. They can be challenging, right? It's a challenging demographic, but it's also extremely gratifying, can be extremely rewarding. I have a stack of thank you cards in my office, and not one of them is from somebody saying, thanks for getting my blood pressure down to 130, or thanks for getting my A1C to less than 7. They're all from my OUD patients. It's just amazing to watch them get their life back. They get a job, they get an apartment, they get their vehicle. Some people get their kids back. It's really rewarding. So lots of great resources. I just want to mention, I didn't really touch on the Vivitrol, but that is definitely an option, right? Vivitrol, I don't know, Dr. Hankey, I was having some issues with it, getting it covered for the diagnosis of opioid use disorder, even though it is a FDA indication. It is, last time I checked, still covered for alcohol use disorder, which a lot of times if there's one, there's another anyhow. So here are some different provider resources. SAMHSA is great. CA Bridge, which I think Abby also may have shared. It may be known as buprenorphine Bridge now. Project Echo, there's a lot of good programs reported there. PCSS, this is excellent, an excellent source for anything MOUD, buprenorphine. I like that as well. So I think that's kind of it for me.
Thank you.
Yeah.
We really appreciate the conversation from both you and Dr. Hankey. Now we'll open it up for questions. You're able to come off mute if you'd like. I know we have at least one in the chat, so I'll start with that one. So being in a rural area, do you have any difficulty connecting a patient with support services such as LACs or other services?
Yes, definitely. So I don't have any LACs really available right in Candu, except for at Heartview Foundation, the residential and outpatient treatment center. So certainly I do give people their number to call and they can do an assessment. And then about 30 miles away is Devil's Lake. I have quite a few patients in that area and I have good licensed addiction counselors there I can recommend. So yeah, there's definitely not enough of them. So use what's available. But I will say too that just look up LAC and reach out to them and say, hey, I'm thinking about doing this. Are you willing to help me? And I'm sure a vast majority of them would be happy to help work with you.
And that's precisely why we wanted to have this webinar, is to really encourage the breaking down of those silos between primary care and behavioral health and just community resources, like start the conversation, make the phone call, develop colleagues. Exactly. I'm not seeing other questions. Is there anyone else in the crowd? Another one from Lisa. How about transportation? We hear that a lot. Many patients have issues with dependable transportation.
Yeah, so for me, I have a lot of patients that come from reservations. I'm kind of situated between 2 reservations and they're both about 30 to 45 miles away. There is tribal assistance for that. They just have to call and get it scheduled for those people. Or alternatively, if they can take a personal vehicle, I write them a note and they'll reimburse them with a gas card. And then I do have some patients that are not tribal members, and Medicaid can provide transportation as well. It's a little tricky. You can't schedule it more than 2 weeks, but it can't be closer than 3 days. But if you can call call your Medicaid number, there is transportation available.
We've
And
also learned.
that's also
Oh,
true
go
for
ahead.
Medicaid expansion. Sorry. So
I was gonna say the
Medicaid and
same thing.
Medicaid expansion, at least in North Dakota, I can't speak for South Dakota, but in North Dakota, Medicaid and Medicaid expansion will both provide transportation.
Yes. Another question. Excellent presentation. This is from Gordy Langang. Why is it that methadone seems to be the preferred medication over bupe? Can you also speak to the issue of cost?
Sure. So, and I'm going to take this because I don't think Grant has methadone up in Can-Do.
Correct.
So I really think that part of the reason stems from, in North Dakota anyway, our insurance caps buprenorphine at 24 milligrams a day. If you look at data coming out of California and some of the other states, it tends to be they're using 32 milligrams up to 40 milligrams a day because of the potency of potency of fentanyl. So in North Dakota, once you hit 24 milligrams a day, your insurance isn't going to pay for anymore. And if you've been using fentanyl up to 5,000 micrograms a day, that 24 milligrams of buprenorphine is not going to cut it. And so with methadone, we can titrate up to effect. And I will say that at Heartview, our highest patient is on 320 milligrams of methadone every single day, which gives me a little bit of chest pain. And I hope it gives all of you a little chest pain. But that is probably the issue why patients want the methadone. The other issue is that methadone doesn't precipitate withdrawal, whereas buprenorphine can. So when you're in that induction phase with buprenorphine, people can have precipitated withdrawal that doesn't happen with methadone. And so if they've used it on the street and it put them into withdrawal, they just want no part of the buprenorphine. Whereas the methadone, they know that they will be able to tolerate it. So, but if you live in rural North Dakota and there's no OTP, then people are going to have to make do with buprenorphine, and usually they do just fine. Yep.
Awesome. Thank you. Another question. I work in a behavioral health hospital in South Dakota. We are getting feedback that MOUD should be initiated inpatient. We struggle with the transfer of care to outpatient and just treat symptoms inpatient. Thoughts?
Like I alluded to earlier, I do, what's buprenorphine anyways, it's Suboxone. I do 98% home initiation. They pick up their script and they go home and they do it and they follow up because it works. It's not dangerous. If you can prescribe, like I said, oxycodone, Norco, Xanax, maybe you should be initiating that in the hospital. Sorry, I'm a little jaded, but no, it's not necessary.
And I would say if you are someone that is doing it inpatient and you can't find outpatient providers and you believe in this medication, then you need to make some phone calls. And I know that I've done that. I know Grant has done that. Before Grant was prescribing in Can-Do, our catchment area from Bismarck extended from Belle Fourche, South Dakota, Sidney, Montana, to Fergus Falls, Minnesota. And we saw everyone in between. And so I ended up picking up the phone and just calling people saying, hey, I need a prescriber here, there, and everywhere. So can you help me out? Because I can't do this. It's not feasible for my patients to travel 5 hours to see me. And so little by little, if you can get other providers to work with you and you can have that smooth handoff, because people are afraid. The only reason that people don't want to do this medication is because they don't have the experience and they're afraid of what it means. So if you can assure them, this is easy. This will be the most rewarding thing that you do in medicine. And it's not scary. It's not dangerous. It's not complicated. But you have to have those conversations. So reach out to your outpatient colleagues and say, hey, I really need someone to take these people over. Are you willing?
Fantastic. I appreciate the guidance, and I noticed that Abby has put several links in, just making some of these connections, self-start guides. We'll make sure that all those are emailed out. So again, we'll email out the recording and the slides, as well as those resources. Any last comments before we sign off today?
Heather, I see there's one more question in the chat.
Okay, thanks. Do you have patients that are unable to start buprenorphine because of the expense?
It's been a long time, I guess. It's well covered with insurance. If they don't have insurance, that's where you're going to run into an issue. I haven't had to use it for a long time. Dr. Hank, I don't know, is there still that Zubsolv coupon available online?
So if they have access to GoodRx, you can
Yeah.
typically get a month's supply of GoodRx for under $100. So it's not as expensive as it used to be. And the other thing is typically buprenorphine is combined with naloxone to make Suboxone. If you use just the solo product of buprenorphine alone, it's always under $100. So, again, the naloxone's only in there to prevent people from injecting it, and I don't think a lot of people are injecting. So if you want to go down that road, I would go that route just for
And-
cost purposes. But most of my patients are eligible for Medicaid or Medicaid expansion.
And I would also add that, up here in Can-Do area, I know a tab of fentanyl is anywhere from $50 to $80, whereas in like Grand Forks, Fargo, Bismarck, it might be closer to 10 to 20. So if you're up here and sustaining a 5-tablet a day habit at $50, that's $250. I don't want to know how you're getting your money, but you obviously have a way to get some money.
Right.
And the question in the chat was about telehealth, and absolutely telehealth is an option for most providers. As far as insurance companies, they will typically pay for it. It is legal. Prior to COVID, you had to see someone face to face to start these medications. That's not the case anymore.
So I will say in our area with a rural health clinic, yes, I can do telehealth, but the reimbursement is so poor that my administration does not want me to do it, unfortunately, because I make more money seeing people physically in the clinic. And unfortunately, when it comes down to it, this is a business, right? We have to keep the lights on. But you could also add too that doing MOUD adds to your practice. It's probably 20% of my practice, maybe not, if not 25 or 30% on a day-to-day basis.
Fantastic. Well, again, your expertise has been very insightful for us today, and we appreciate it. And I hope to continue to make connections between your network and the work that we're doing. Let us know if there are any questions, and we'll get information sent out.
And this is Carrie. I'll just close out really quick with a reminder that all registrants will get a certificate of participation. You can submit that to your accrediting or licensing body for CE credit. We'll send that via email along with the link to the recording. And with Dr. Hinkie and Grant's permission, we'll also share their slides. I'll follow up with them after this and make sure that that's okay. And the Opioid Response Network has a survey that we will send to you via a link later this week. If you could please take 5 minutes and offer us your feedback, that would be great. Thanks again to Dr. Hinkie and Mr. Lanoy for sharing your knowledge and your passion and your experiences with us. And to all that took the time to join us today, thank you for the conversation on this really important topic. Thanks, and we'll catch you next time. Have a great day.